Slit lamp biomicroscopy is a technique for examining the eye at various magnifications, as for example the fine structure of the iris shown here. But many tissues in the eye are transparent and therefore invisible. They must be made visible before they can be examined. This is possible as shown here in a case of congenital absence of the iris by special techniques which allow one to see the transparent cornea, the transparent lens, the transparent zonules, and the transparent anterior vitreous. For this purpose, the slit lamp, besides allowing the examination of visible tissues in great detail, as shown here by the example of floating remnants of a pupillary membrane of the iris, also offers additional methods for examination. Actually, the slit lamp is a unique instrument because it makes even the invisible visible. How is this possible? This is accomplished by generating 4 optical phenomena which occur in transparent media, that is, light scattering, reflection, refraction, and absorption. Before explaining these phenomena, some problems related to accessing the eye interior shall be discussed. This case of white asteroid bodies floating in the vitreous show that the slit lamp permits the visualization of the anterior third of the globe only. That means much less than with an ophthalmoscope. Special auxiliary devices are needed to reach the posterior fundus, which allow us to follow the asteroid bodies up to the preretinal vitreous and also to see the retina and the disc. Why is that so? Let us explain. The light rays from the posterior fundus emerge parallel from the eye under examination, and parallel rays are brought into focus at the retina of the observer's eye. Emitted and accepted rays coincide. This is why we can see the fundus in direct ophthalmoscopy. However, if the eye of the observer is equipped with auxiliary optics such as a microscope, it accepts only rays from a defined focus, that is, divergent rays. In the eye under observation, only points in the anterior third of the globe emit rays divergent enough to be caught by the microscope. The rays, which come from areas more posterior and which normally emerge parallel, must be made divergent before they can be accepted by the microscope. This means if the eye of the observer is equipped with an auxiliary optical device, the eye of the patient must also be equipped with an auxiliary optical device in order to see the posterior parts of the eye. The auxiliary optical devices are correcting lenses set between the eye and the microscope. These are either minus or plus lenses. But how is it possible that both minus lenses and plus lenses, that is, lenses with opposite optical properties, permit the visualization of the posterior parts of the eye? The minus lens renders the parallel rays divergent so that they can be accepted by the microscope. The plus lens makes the parallel rays convergent and brings them first into focus in front of the lens. From this focus, the rays emerge divergent and then can be accepted by the microscope. Therefore, both types of lenses provide divergent rays. But note the difference in the distance which will occur between the eye of the patient and the microscope. Furthermore, there is a difference in the results. Seen with a plus lens, this case of retinal surgery with an encircling band can be scanned beyond the equator. The high-power plus lens provides a wide field of observation similar to indirect ophthalmoscopy. But note, the magnification is low and the image is inverted. A minus lens, in contrast, provides results rather similar to direct ophthalmoscopy. Here, in the same case of retinal detachment surgery, the image is straight, the magnification is higher, and one can see more details, such as these fine retinal folds. The field of observation, however, is smaller with the minus lens currently used. Plus lenses are either held by hand in front of the patient's eye, as with the Hog-Strite 90 diopter indirect preset lens, or they are in direct contact with the eye, as with the Folk transequator lens. Likewise, minus lenses are either preset, like the Ruby lens, or they are contact glasses, like the Schirmer lens. A special case are the plano-concave contact glasses, which have a flat front surface, as for example the Goldman fundus contact glass. They are minus lenses because their posterior surface is concave. The plano-concave contact glasses are designed to reproduce the spatial relations of the eye interior with the greatest possible accuracy obtainable in a living eye. For example, in this normal eye at the fundus, the deformation of the field is minimal, and when the slit light is made narrow, its curved outlines correctly show the normal curvature of the fundus. And if the focus of the slit lamp is moved more anteriorly, the anterior segment with the lens appears in an almost natural shape. Note: the lens seen without contact glass appears thicker than when seen with the plano-concave contact glass. Why is that so? The cornea acts as a plus lens and magnifies the natural lens. The plano-concave contact glass abolishes the power of the cornea and consequently the magnification. In contrast to the correctly imaging plano-concave contact glass, with the wide-angle plus lens the equator of the globe is expanded. The posterior fundus appears flattened. Due to this flattening, a narrow slit is seen straight instead of curved. Furthermore, the peripheral parts of the fundus are stretched so that lesions in the periphery appear enlarged. When scanning a wide field with the high-power plus lens, this flattening is an advantage because large areas can be sharply seen despite the low depth of focus of the microscope. A narrow slit, however, appears straight. In the anterior segment, based on heavy deformation, the lens looks like a banana. This deformation may be a clinical problem. When interpreting pathology, such as the slight prominent macular hemorrhage seen here, the flattening suppresses the prominence because any three-dimensional changes become less recognizable. But with the plano-concave contact glass with the narrow slit, even the tiny elevation can be recognized by the uneven curvature. So, three-dimensional phenomena are better imaged with a plano-concave contact glass. Plus lenses, on the one hand, visualize the two-dimensional extent of the fundus and offer a large field. Plano-concave contact lenses, on the other hand, visualize the eye in its three dimensions with great spatial fidelity. In other words, the criteria for the choice of the proper auxiliary device are the size of the field of observation versus the fidelity of exact spatial representation. If preference is given to the wide field, one has to accept the inconvenience of the spatial deformation. If preference is given to the fidelity of spatial representation, one has to accept a restricted field of observation. But with plano-concave contact glasses, there is another way to examine a wider field: the use of mirrors. For access to the periphery, plano-concave contact glasses have been designed which are equipped with mirrors of different inclinations. The classical example is the three-mirror contact glass of Goldman's. The posterior pole of the eye is observed through the central portion of the contact glass. The more peripheral parts are seen through the mirrors with different inclinations. The steepest mirror gives access to the mid-periphery, and the intermediate mirror to the equatorial fundus. The flattest mirror shows the pre-equatorial fundus and the region of the chamber angle. All mirror contact glasses, however, have an inconvenience. Only those parts around the axis of the eye are seen directly. but the peripheral parts can be seen only inverted by the mirrors. The complete image of the eye interior, therefore, must be combined in the examiner's mind from direct and inverted components, but this is easily mastered with practice. While the rays from the fundus up to the equator can pass through the anterior lens surface, any ray originating from a more anterior area is reflected at the lens surface. As shown at higher magnification, a ray from the outermost periphery reaches the anterior lens surface at a critical angle, shown red, that is, at the angle at which rays are totally reflected. Therefore, a ray from the outermost periphery outlined here in white cannot leave the eye. If so, is it really impossible to visualize the outermost periphery? No. There are conditions under which the periphery can be seen. When either the lens position has changed, or when the position of the fundus periphery has changed. In a normal eye, a scleral depressor can be used, which displaces the peripheral sclera towards the center of the globe, and thus into the visible blue zone demonstrated by this animation. As shown at high magnification by this displacement, the angle between the ray and the anterior lens surface increases, becoming higher than the critical angle, and thus the ray can pass. Therefore, scleral depression permits rays from the outermost periphery to leave the eye. When the scleral depressor is applied to the eye, the observer sees a protuberance in the mirror of the contact glass. On this protuberance, the ora serrata can be seen, and in the case shown here, even some small atrophic holes are observed. The area anterior to the ora serrata is the pars plana of the ciliary body. Without scleral depression, the outermost periphery can only be seen if the lens position has changed. On the one hand, the periphery becomes visible if the lens is completely absent, and thus cannot interfere with the rays from the periphery, that is, an aphakia. Also, the lens does not interfere when it has been posteriorly displaced, that is, in posterior subluxation of the lens. Therefore, in this case of traumatic posterior dislocation of the lens, in the mirror of the contact glass, which is on the opposite side, the periphery can be seen with the peripheral retina and the retinal vessels, the ora serrata, and the ciliary processes. On the other hand, the outermost periphery becomes visible if the lens has been anteriorly displaced. Then the optical conditions for visualization of the equator become valid for more anterior parts as well, and so rays from the outermost periphery can pass through the anterior surface of the lens. For example, in this case of angle closure glaucoma, with a flat anterior chamber, the lens has moved anteriorly and blocks the chamber angles. In the contact glass mirror, the ora serrata and even the interior part of the ciliary body with the ciliary processes become visible. Note, in contrast to a posterior displacement of the lens, in case of anterior displacement, the ciliary processes appear magnified because they are seen through the lens. Further, there is some disturbing optical degradation due to astigmatism of the lens border. So the main obstacle for viewing the outermost periphery is the lens. And what is the role of the pupil? Actually, whether the pupil does or does not obstruct the view on the periphery depends on its position, either posterior or anterior. This diagram shows a ray from the fundus periphery and how the pupil interferes. A pupil which is far posterior must be wide in order not to obstruct the view on the periphery. A narrow pupil is an obstacle unless it is in an anterior position. Therefore, in an eye in which the lens has pushed the iris forward, even a narrow pupil permits a view of the peripheral fundus. For example, this is the other eye of the patient with the flat anterior chamber we saw before, but here the pupil is narrow, The narrow pupil, of course, restricts the field of view, but nevertheless, even the ciliary processes can be seen here. If we look through the pupil, here seen with a contact glass, 3 bundles of rays must pass the pupil, the 2 bundles of the microscope lenses and the bundle of rays of the illuminating light. In the case of a narrow pupil, space may not suffice for all 3 bundles to pass. Here there can be neither light nor binocular vision. To restore illumination, the light is approached to the observation beam by moving the light beam towards the microscope. To restore binocular vision, the distance between the microscope bundles must be reduced, and with proper alignment, a position can be found which allows all 3 bundles to pass. A special optical device, the stereo variator, has been designed for the reduction of the distance between the microscope bundles. Of course, with a stereo variator, the reduction of the angle of binocular vision reduces the stereoscopic effect, but other benefits of binocular vision are preserved, such as the size of the binocular field and better visual acuity. As mentioned earlier, the invisible becomes visible when the slit lamp is correctly used. All it needs is proper illumination. The important point is, and this must be stressed again and again, that the light is applied deliberately, similar to a tool, for generating specific optical phenomena, that is, as a tool which can create, enhance, and even dissect. The design of a slit lamp provides such a tool. The slit lamp has a moving observation system, the microscope, and a moving illumination system, the slit beam. The actions which are used for generating the optical phenomena can be described by 2 angles, the illumination angle and the observation angle. Let us describe first the illumination angle. The illumination angle is the angle between the light beam and the observer, that is, the microscope. Please note these pictograms which will be used throughout the following sequences. Basically, there are 3 main directions of an incident light beam. Light from the direction of the observer, that is from the front, then the angle between observer and the light beam is about 0 degrees. Light from the sides, the illumination angle is about 90 degrees. And light from the back. The illumination angle is about 180 degrees. Every illumination angle provides different information about an object. An optimal examination strategy means do not just look at what you see. Skilled examiners look for what they want to see. For example, for the detection of minimal turbidity, that is, a minimal imperfection of transparency. Light scattering is generated. This is demonstrated here in a cube filled with smoke, which is invisible unless a bright light beam renders its even minimal turbidity visible through the so-called Tyndall phenomenon. For the evaluation of a surface, reflexes are generated. This is demonstrated here by the cube on which reflexes make the surface visible, as well as some scratches now seen on this surface. For detecting transparent objects with a different index of refraction, the deviation of light coming from the back is examined. This is demonstrated here by glass balls in the transparent cube, which have black margins, because light coming from the bright background has been refracted away. And for the evaluation of the degree of a localized intransparency, the absorption of light coming from the back is examined. This is shown here by black balls in the cube which prevent the light from the background from reaching our eyes. So 4 optical phenomena can be used for the examination of transparent media: light scattering, reflection, refraction, and absorption. What illumination angle should be chosen for slit lamp microscopy? The choice of the angle in a given situation depends on the goal of light application. These angles shall be explained by a case of chronic anterior segment inflammation. If the goal is the generation of light scattering, the illumination angle should be as close to 90 degrees as conditions permit. This is shown by the cross-section through a lens, which, although transparent, becomes distinctly visible. Here it is in sharp focus at the anterior cortex. Here at the center at the lens nucleus, and here at the posterior cortex where a subcapsular cataract exists. If the goal is the generation of reflexes, the angle should be variable, as shown by reflexes here at the anterior lens surface and here at the posterior surface. If the goal is the evaluation of the effects of absorption and refraction, the angle should be 180 degrees. This is shown in this posterior subcapsular cataract where the phenomena of absorption and refraction are seen in backlight with fine details shown at high magnification. Not all angles can be obtained by direct illumination due to anatomical constraints. If direct access of the light to the target is impossible, one has to use indirect light produced within the eye. This is achieved by projecting light against a non-transparent tissue such as the red fundus, which then acts as a reflecting screen. Other sources of indirect light are the iris and, in some conditions, the lens. Thus, the eye interior can be transformed into reflectors for generating indirect light. For observing an object in indirect light from the fundus, the light beam is directed away from this object towards the background. There, the rays are reflected. They will provide backlight, also called retroillumination, for a target which is far away from the fundus. A target which is very close to the fundus may also be illuminated from the side, and this is called lateral indirect illumination. Similarly, the indirect light from the iris can be obtained by directing the beam away from the target towards the iris, and from there, backlight and lateral indirect light are produced. In addition, even a transparent medium such as the lens can be made to be an indirect light source by reflexes at its anterior or posterior surface, or scattered light produced within the lens. With this in mind, we will now discuss the illumination techniques for the generation of optical phenomena in more detail. What is the purpose of the examination of light scattering? It allows the visualization of minimal imperfections of transparency which otherwise are invisible. In the eye, it is used for the visualization of the cornea and the lens. Here, the light scattering phenomena are quite strong. Scattered light is further used for the detection of weak pathological phenomena in the anterior chamber, which are nearly invisible here but can be made visible by using proper techniques. The best technique for generating light scattering is an illumination angle of 90 degrees, but this is only obtainable in the anterior segment. The more posteriorly the examination proceeds, the more restricted the choice of a large illumination angle becomes, and the conditions for examination with scattered light deteriorate. How can we optimize our observation of light scattering? This can be done by choosing a dark background, maximizing the sharpness of the margins of the light beam, maximizing the brightness of the light beam. An excellent dark background is, for example, the black pupil. For recognizing even faint scattering, the light beam should be made sharp and short so that both margins can be observed against the dark background. Comparing the area of scatter and the non-scatter vicinity improves the identification of very faint scatter. And finally, scattered light can be increased by maximizing the brightness of the light through hypervolting the light bulb. Hypervolting also proportionally increases the contents of short wavelength rays, which are especially effective for generating scattered light. Both the maximum of brightness and of sharpness of a given light source exist at the focus of the light beam. Therefore, the observation of scatter is optimal if the focus of the microscope is exactly at the same place. In other words, the focus of the light beam and of the microscope should precisely coincide. The coincidence of focus is an essential feature of slit lamps and will be discussed in detail later in this series. Reflexes occur at surfaces between media with a different index of refraction. Where do reflexes occur in the eye? Light is reflected at the anterior and posterior surface of the cornea, at the anterior and posterior surfaces of the lenses, and at the anterior surface of the retina. These surfaces act like mirrors. The examination of these mirrors is called examination by specular reflection. In this normal eye, we see a very strong specular reflex at the anterior surface of the cornea, weaker reflexes at the posterior surface of the cornea, at the anterior surface of the lens, and at its posterior surface. In this case of pre-retinal fibroplasia, we see reflexes at the anterior surface of the retina. Which factors determine the size of a specular reflex? With a normal lens, the specular reflex is larger at the anterior lens surface, which is flatter, and the reflex is smaller at the posterior surface, which is more curved, because for a given light source, the size of the specular reflex depends on the curvature of the surface. However, in this case of traumatic cataract, the reflex becomes abnormally large, because here the anterior lens surface is abnormally flattened. Therefore, the specular reflex is wide and covers nearly the entire pupillary area and hides the star-shaped cataract. What is the clinical purpose of examination by specular reflection? There are two main purposes: the evaluation of the texture of a surface and the evaluation of the position in its relation to other objects. In the evaluation of texture, as seen here at the anterior lens surface, the specular reflexes are extremely sensitive. Even tiny irregularities can easily be seen, irregularities which are far too small to be detected by other techniques of biomicroscopic examination. For defining the position of a surface and its relations to other objects, specular reflexes are very precise. If an object is behind the surface, the specular reflex will be intact. If the object is in front of it, the reflex will be disturbed. For example, in this case of a normal lens, grayish nodular and curved structures appear somewhere near the posterior lens surface. When scanning the posterior lens surface, the specular reflex is undisturbed. Therefore, the grayish structures must be behind the lens surface and can be identified as parts of the hyaloid artery. On the other hand, in this case of a posterior subcapsular cataract, there are lesions which, as the higher magnification shows clearly, disturb the reflex of the posterior lens surface. Therefore, the lesions must be in front of the capsule, that is, they are situated in the posterior lens cortex. According to the law of reflection, specular reflexes can be observed if the angle of the incident ray to the perpendicular is equal to the angle of the reflected ray. In clinical situations, however, the perpendicular is not known for every single point because the inclination of the observed surface varies. An illumination angle of nearly 0 degrees reflects the light rays almost automatically into one of the microscope lenses. Using this easy way, however, only the most superficial tear film reflex can be observed. For the deeper parts of the eye, the tear film reflex is always an obstacle because it blurs the view into the eye interior. In order to remove superficial reflexes, a large illumination angle is necessary for observing deeper situated targets. This is shown here at the cornea, where the tear film reflex prevents the view on the specular reflex at the posterior corneal surface. The specular reflex of the corneal endothelium becomes visible only when the illumination angle has been increased, and this is a prerequisite for the hexagonal pattern of the endothelial cells to be seen on the left of the tear film reflex. Then how can we find the specular reflex in a given clinical situation? The proper illumination angle is found empirically by considering three factors: the microscope, the illumination unit, the instrument base with the microscope and the illumination unit. Depending on which of these three factors is varied, three basic techniques of examination can be distinguished. Theoretically, the simplest approach is to preset a large illumination angle and then to keep this angle stationary, to approach the target by moving the instrument base, and to rotate the microscope together with the illumination unit. The angle is large and fixed by screws. The target is approached, and then the microscope is rotated. Here we see the anterior lens surface brought into focus at a given area. The microscope, together with the illumination unit set at a fixed angle, is rotated from the right to the left, as can be seen by a slight change in perspective of the lens, until the specular reflex begins to appear on the lens surface. The rotation of the microscope, however, may be uncomfortable because it requires a torsion of the examiner's head. Therefore, the examiner may prefer techniques in which the microscope is kept stationary. In a second technique, the examiner presets the target by adjustments of the instrument base. Just the illumination angle is varied by rotating the illumination unit only until the specular reflex is seen in one of the microscope's eyepieces. Now the examiner's head remains comfortable, only the slit beam needs to be rotated. Here, the anterior lens surface has been brought into focus at a given point. As can be seen on the right by the movements of the light strip on the cornea, the light beam is rotated towards the left until the specular reflex appears on the lens surface. In the third technique, the microscope and illumination unit are kept stationary, and only the instrument base is shifted. This means that the tissue surface is scanned until the specular reflex appears in one of the eyepieces. However, in this technique, the point at which the reflex will be observed cannot be known in advance. Now again, the examiner's head is comfortable and the instrument base only is shifted. In the examination of the anterior lens surface, for example, the slit lamp is guided along the lens surface from the right to the left until the point is reached where the reflex eventually appears. If, during the examination, the observer rotates the microscope, the specular reflex will disappear. To restore specular reflection, the light beam should be rotated in the opposite direction of the microscope according to the law of reflection. Here, the specular reflex disappears from the anterior lens surface as soon as the microscope is rotated to the left. To re-establish specular reflection, the illumination unit is rotated to the right. Thus, on rotation of the microscope, the slit beam is rotated in the opposite direction. For scanning along a large convex surface with the microscope in a fixed direction, the illumination unit must be rotated in the direction of the scanning movement, that is, when moving from the left to the right, rotated to the right. In contrast, when scanning from the right to the left, the illumination unit must be rotated towards the left. Thus, the scanning movement of the slit lamp is combined with a rotation of the slit beam in the same direction. Here, at the anterior lens surface, the slit lamp is shifted to the left, and hence the specular reflex is lost. To re-establish specular reflection, the illumination unit must also be rotated towards the left. As the shifting movement of the slit lamp continues, this procedure is repeated for every step. Here, and again, and again. If the tissue not only consists of a homogeneous distribution of molecules which causes light scattering, but also contains a non-homogeneous distribution with internal surfaces causing reflexes, scattered light and reflexes occur simultaneously within the same field. For example, in this lens with congenital cataract, one can see zones of increased brightness. One zone of brightness is due to an increased scattering of light, indicating a pathological process. Another zone indicates just internal reflections in a normal lens cortex. How can we distinguish between the two phenomena? One difference is the size of the generated optical phenomenon. Here, within the lens, the effects of scattered light are as large as the illuminating beam. In contrast, the specular reflexes at the capsule are much smaller, depending, as explained earlier, on the curvature of the reflecting surfaces. Another method of distinction is based on the variability of reflexes. The reflexes disappear when the illumination angle is changed, while the effects of scatter remain, and by varying again the illumination angle, the reflex can be made to reappear. The reflexes can also be identified by changing the position of the target. The reflex moves up and down if the patient is asked to look up and down, while the effects of scatter remain unchanged.
When backlight from a distant light source arrives at our eye unimpaired, the observer sees an evenly illuminated background. When a transparent obstacle deviates part of the rays, these do not reach our eye and the respective area appears dark to the observer's eye. How does this occur? Consider the existence of a spheroid obstacle with an index of refraction differing from the ambient medium. Backlight will pass beside the sphere directly to the observer. Backlight will also pass undisturbed through the center of the sphere. The peripheral rays, however, are bent. In case of a lower index of refraction, they diverge directly. In case of a higher index of refraction, they diverge after having converged first. Therefore, the peripheral rays do not arrive at the observer's eye. As a result, the margins of the observed object will always appear black, while the surroundings, as well as the central parts, will be seen in the color of the background. The appearance of a refraction phenomenon depends upon the curvature of the refracting object. This is shown here by the example of a flaccid bullous detachment of the corneal epithelium, seen against the red backlight from the fundus. When the fluid within the bubble is shifted, the curvature of the bubble varies and so does the refraction phenomenon. Further, the appearance of the refraction phenomenon depends upon the color and the shape of the backlight. Here, the part of the spherical object seen against the dark background appears bright, and due to the imaging properties of the refracting objects, the part seen against the bright background is dark. Such a contrasting background visualizes corneal microcysts at a high contrast. What is the purpose of observing refracting phenomena? This technique allows the visualization of alterations which are hardly visible by other techniques of illumination. An example is this epithelial dystrophy of the cornea. The epithelium is a layer too thin for tiny phenomena of scattered light to be easily detected. However, by observing refraction phenomena against the yellow backlight from the iris, the very fine changes in the epithelium are easily recognized by distinct dark lines and outlines. How is the backlight produced in clinical conditions? The light source is the indirect light reflected from non-transparent tissue behind the refracting target. The illumination angles can be widely varied for retroillumination from the iris. For retroillumination from the lens, the illumination angle is chosen wide in order to obtain intense scattered light. For retroillumination from the fundus, the angle must be narrow because it is limited by the size of the pupil. How can refracting phenomena be detected, for example, in this case of anterior and posterior cataracts, when neither the existence nor the position of refracting lesions are known in advance? First, retroillumination is established. Then the area where lesions are suspected is scanned in its entire depth by moving the microscope back and forth. Small magnification is used because it has the advantage of the maximum depth of focus, which allows one to see opacities from many levels at one glance. Then magnification is increased for determining the exact position of a specific lesion. Since high magnification reduces the depth of focus, objects are only seen at one level. Here only, the anterior subcapsular cysts are in focus, while the posterior subcapsular lesions are barely visible. The distance between them is estimated by shifting the microscope backwards, which brings the posterior lesions into sharp focus, while the anterior cysts become unfocused. The observation can be greatly improved by using the method of backgrounds with contrasting borders explained above. Such contrasting borders can be found at anatomical margins, such as the pupillary margin in this example of corneal edema. While microcysts of the epithelial edema are hardly visible elsewhere, they are easily recognized here. Furthermore, by narrowing and shifting the beam, contrasting borders can be generated artificially by the examiner. Now the microcysts of corneal edema become visible against the margins of the light beam on the iris. When examining with high magnification, the field of observation is small. In order to bring the margins of the background light into this small field, the illumination angle should be decreased. For targets which are close to a reflecting screen, another technique can be taken advantage of: lateral indirect illumination. Light arrives at the target not only from the back, but also obliquely. If the object has a lower index of refraction than its environment, reflection will occur on the same side as the incident light, and an illuminated crescent will be seen there. If the object's content is of a higher index of refraction, the object may act as a light guide, and the light is guided to the side opposite the incident beam. Due to internal reflection, the illuminated crescent is seen on the opposite side of the incident light. Examples of such targets are lesions in the corneal periphery, which are close to the reflecting iris, or targets in the posterior vitreous and the retina, which are close to the reflecting disc or choriocapillaris. To illustrate these phenomena, an exceptional case of glaucoma surgery is shown. Air injected into the anterior chamber has been expulsed beneath the conjunctiva. There, the air bubbles are invisible in general illumination, but they can be made visible with indirect lateral illumination. Here, the margins of the air bubbles are illuminated on the same side as the incident light, due to their lower index of refraction. Another exceptional example is this case of retinal surgery, where silicone oil was used. Residual silicone oil bubbles in the conjunctiva are made visible with indirect lateral illumination. Here, the margins of the bubbles are illuminated on the side opposite the incident light, due to their higher index of refraction. In this technique, the observer identifies absorbing objects. Such objects always appear black when seen in backlight, whatever their own color and whatever the color of the backlight. How can absorption phenomena be generated? Retroillumination is used similarly to the examination of refracting phenomena from the iris, from the lens, as well as from the fundus. For example, in this case of retinal detachment, there is a barely visible pre-retinal floater adherent to a vessel which runs across the retinal tear. This floater appears brown in direct light because it is pigmented and the vessel appears red. In retroillumination from the fundus, however, both appear plain black. What is the purpose of checking for absorption phenomena since opaque tissue is visible anyway? One purpose is to distinguish between objects that are really opaque and other objects that only appear so. In direct light, we can see truly opaque objects by light reflected diffusely at their surface. Transparent objects, due to scattered light, may appear similar. Backlight allows the distinction. Opaque objects prevent backlight from passing. On the other hand, backlight can pass through light-scattering objects so that these appear transparent. An example is the analysis of cataractous changes, which all appear whitish in direct light. In retroillumination, some of these changes disappear because they are transparent, and their whitish appearance was then due to light scattering. Others appear black in retroillumination because they are truly opaque. The difference between direct light and backlight is thus seen here. Similarly, the examination of absorption can be used for analyzing the degree of pigmentation. These spherical tumors of the iris appear solid when their surface is observed in direct light. In retroillumination, however, a strip of backlight visible behind the brown sphere indicates it is partially transparent, and therefore it is not a tumor but a cyst. Another important purpose is to find out what happens behind light-scattering layers. Direct light makes such layers non-transparent. Retroillumination, however, shows where hidden opaque tissue exists and where it is absent. In this example of chronic iritis, the iris appears normal when illuminated from the front. In backlight, however, defects in the pigment epithelium due to inflammation and surgical trauma are revealed as red spots in the color of the fundus backlight. Sometimes the phenomena of absorption and refraction look very similar, although their clinical significance may be different. How can we distinguish between them? The phenomena of absorption are rather invariable at different conditions of observation, while phenomena of refraction vary with the background. Here are two examples of vitreous floaters which look similar in direct light, but one is clinically significant and the other is not. The absorbing floater always appears black, as here, by the inflammatory deposit on the posterior vitreous surface in case of an inflammation of retinal vessels. And when the absorbing object moves and is slightly out of focus, the center will always remain black, and only the margins will be blurred. To the contrary, refracting phenomena look different when the shape or color of the background changes, or when their distance from the background varies. For example, this clinically irrelevant remnant of the embryonic hyaloid artery floating in the vitreous is transparent and refracting. When the floater moves, its margins remain dark, in contrast to absorbing objects. The position of the dark side varies depending on the position of the object to the backlight. Here, the dark margins are seen at the right side of the floater, and here at the left. Let us look back for a moment. The basic methods for visualizing transparent tissue are the generation of light scattering, the generation of reflexes, the observation of refracting phenomena, the observation of absorption. These four methods are applied by two illumination modes. One mode is direct light and consists of scattered light and specular reflection. The other mode is indirect light and consists of refraction and absorption phenomena. Now the main problem is that the two modes, that is, direct and indirect light, are antagonists and interfere with each other. Therefore, a skilled observer tries to keep them separated during the examination in order to prevent this interference. For example, the phenomena of direct light at the cornea, that is, scatter and reflection, hide the structures behind the illuminated corneal tissue because they make this tissue non-transparent. On the other hand, indirect light decreases the visibility of scattered light and reflexes at the cornea and improves the visibility of objects behind it. This diagram shows a vascularized corneal scar with direct light and retroillumination from the iris in the same axis of observation. Seen through the eyepiece of a microscope, gray scatter and brown backlight overlap. Such an example of a vascularized corneal scar is shown here. On the right-hand side of the light strip, the area illuminated by direct light reveals the light-scattering properties of the scar. On the left-hand side is the area of indirect light showing superficial and deep corneal vessels against the backlight from the iris. In the central strip, direct light and indirect light overlap, and here they interfere. At higher magnification, we see that in the zone of overlap, the deeply buried vessels disappear behind the haze of scattered light from the superficial layers of the cornea. On the other hand, the scattered light of the scar disappears due to irradiation from the background. Note, the negative effects of interference cannot be eliminated by increasing the brightness of the light, because this, to the contrary, just accentuates the blurring effects. To eliminate the overlap of the two illumination modes, these can be separated by increasing the illumination angle. Then, in the microscope view, scatter and backlight are seen separately because the gray scatter has moved to one side and the brown backlight to the other. With a large illumination angle, by shifting the slit lamp laterally, the illuminated background is brought behind the target. Now in backlight, the vessels buried deep in the corneal stroma can be seen in detail beneath the superficial vessels. The direct light reveals the haziness of the corneal stroma and even an overgrowth of conjunctival epithelium with a sharp margin. Note that narrowing the light beam effectively improves the separation of illumination modes. A second method of eliminating overlap is the decentration of the beam, which, as seen in microscope view, is another effective means for separating scatter and backlight. At the slit lamp, the centering screw is loosened, and then the slit beam can be swiveled from its pre-centered position. This swiveling is shown here at another vascularized scar of the cornea. Here the vessels are blurred by superficial scattered light. When the light beam is decentered, the vessels clearly appear by the absorption phenomenon of blood cells in the retroillumination from the iris, and even the movement of the cells can be seen. And here appear refraction phenomena caused at the surrounding vascular walls. The incessant change of illumination methods needed for a proper examination requires versatile slit lamps designed for easy variation of illumination angles. Just as important is an easy variability of the light beam shape. When searching for lesions within a large field, obviously a wide beam is needed, as shown here in the example of an anterior mosaic crocodile shagreen in the cornea. When the margins of the light beam determine the quality of optical phenomena, the size of the beam should be reduced. For the detection of light scattering, the upper and lower margins are important, and therefore the beam is vertically shortened. On the other hand, for detecting refraction phenomena, the lateral margins are important, and therefore the beam is horizontally narrowed. A very special case is the extremely narrow slit beam, which is such an important feature that it has even given the slit lamp its name. Actually, the extremely narrow slit light acts as an optical knife, which can provide an optical section through the eye. What is the purpose of the optical knife? The optical knife reveals the exact outlines of tissue as well as their phenomena in their inner structure with high precision. For example, in the cornea, the optical section can serve for quality control of corneal surgery. In this corneal incision, the optical section through the margins reveals signs of imprecise coaptation, such as irregularities of the outer wound contour, gaps between the wound lips, and a gaping of the inner wound. In the lens, as shown here by the example of a congenital cataract and coloboma of the lens, the optical section reveals, in the cortex, the general lamellar pattern, and in the nucleus, white dots in a zone of disturbed growth during the prenatal stage. At the retina, here a wide-angle view shows the detachment of the perimacular retina. A detail analysis of the macular area proves the existence of two retinal holes by the interruptions of the narrow slit. In the iris, the optical knife reveals any surface irregularities. As shown in this example of an iris in neurofibromatosis, the abnormal iris nodules become clearly visible by their circular outlines. At the disc, the narrow light slit permits the evaluation of the cupping, as shown here in a case of glaucoma. The narrow light slit, which is straight over the retina, becomes deeply recessed at the cupping of the disc, and thus demonstrates its depth. As is shown here by the example of a choroidal melanoma, the optical knife is especially valuable to prove an elevation when evaluating a tumor. At first glance, the lesion appears rather flat. In optical section, the elevation of the tumor becomes apparent. And at higher magnification, the narrow slit light shows the contour of the overlying retina, the surface of the tumor, and a thin layer of fluid between them, proving the existence of a flat retinal detachment. Alternatively, as shown here by the example of a chorioretinal scar with circular vitreoretinal adhesions, the optical knife can also be used to disprove an elevation in cases of suspected tumor. At first glance, the round lesion within the scarred area seems to be a prominent nodule. The optical section, however, is straight and proves the entire area is flat. Furthermore, the optical knife can be used as a marker for defining the focus of the microscope in the examination of poorly defined patterns. For example, in this chamber angle, both the trabeculum and the blood in Schlemm's canal have indistinct margins. Is this fluffy appearance due to inexact focusing or to a real fluffiness of the tissue? Since it is here possible to produce a sharply defined slit image, the microscope is in focus, and thus the fluffy appearance is due to fluffy tissue at the corneoscleral trabeculum. Another example of a chamber angle in which all structures appear blurred is this case of anterior segment inflammation. Again, the slit image is used to show the focus of the microscope. Since the margins of the slit can be made to appear sharp, the microscope obviously is in focus. This proves that the fluffy appearance is not caused by poor focusing but by fibrin. In addition, the optical knife as a focus marker can be used for finding the level at which specular reflexes shall be produced. To find this level, for example, at the anterior surface of a lens, first the optical knife is sharply imaged at the anterior surface to distinguish this surface from other surfaces, such as the nucleus. Then the illumination angle is adjusted, and finally the beam is widened to show the specular reflex. Similarly, the posterior specular reflex is sought by first focusing the optical knife at the posterior capsule of the lens. Then, by widening the light beam, the colored reflexes of a beginning subcapsular cataract are revealed, visible even better here at high magnification. How is an optical knife generated? From a diaphragm with a brightly illuminated narrow slit, a beam is projected into the eye so that the image of the diaphragm is focused at the place chosen by the examiner. But note, the optical knife does not only consist of the focused slit image. In addition, the divergent parts of the light beam in front, as well as those behind the focus, are used for the optical dissection. The narrow slit light, when precisely at focus, is a fine line which reveals a clean profile of different levels. But the outlines of this profile are only seen well at the large angle of illumination. At a small illumination angle, the slit image tends to become straight, whatever the shape of the profile. Instead of its contour, also differences in the width of the slit image can be used. The differences in width remain recognizable even when examining with small angles of illumination. At the level right in focus, the beam will be narrow, while at levels met by the extrafocal parts, the beam will cast a wider light strip. This shows the example of an optic disc with a small central cup. In the temporal part of the disc, there is a difference in level between the rim and a shallow depression which is easily recognized by following the narrow light slit in its contour. Furthermore, the slit is thin at the bottom of the depression because there it is focused, and it becomes wider in the peripheral parts of the disc where it is slightly out of focus. When the light beam is shifted until it meets the cup, the slit becomes wider because the deep cup is behind the focus of the slit. Another example is the glaucomatous cupping seen in this case of a tilted disc. Here the narrow slit is in focus at the upper slightly prominent margin of the disc. The slit becomes wider at the cup and at the inferior crescent of the disc, and it is narrow again at the retinal level. How can the examination of optical sections be optimized? As the example of this lens shows, a maximum of details can be discerned if the phenomena of light scattering and specular reflection are combined. For this purpose, the optical section is brought to a position where specular reflection is reached. Then the optical section reveals previously invisible phenomena in the lens cortex. This can be seen even more pronounced in this example of a cataract in its early stage. The specular reflexes in the optical section enhance the very first signs of the commencement of the lens change with water clefts. The nucleus shows no such zones, and this is a sign of the beginning of condensation. Remember that an area of specular reflection is small compared to the wide area of scattered light. How is the optical knife affected when examining the different parts of the eye? When the optical knife proceeds from the surface into the depths of the eye interior, its properties change. Therefore, adjustments must be made to compensate for the loss of sharpness of the optical knife, the involuntary rotation of the optical knife by the mirrors of contact glasses, the disappearance of the optical knife in the examination of lateral periphery of the fundus. For observing a sharp optical section, the slit light must be focused exactly at the point of observation. That means at the focus of the microscope. The coincidence of focus must be maintained during all movements of the slit lamp. Therefore, the coincidence of focus is set by the construction of the slit lamp right at the common axis about which both microscope and slit beam rotate. However, foci, as set by the construction of the slit lamp, coincide only in an air medium. If the rays from the microscope and slit beam enter the eye, the optical pathways to the target may become unequal, and the present coincidence of focus is lost. The optical section is then no longer sharp. The importance of this problem depends on the length of the optical path in the medium of higher index of refraction. Therefore, it hardly affects the examination of the anterior segment of the eye. But if the optical pathways become long, for example, when examining the posterior segment with a mirror contact glass, the sharpness of the optical knife is lost. How can the loss of coincidence of focus be recognized? This is shown here at the fundus. The retina has been sharply focused at the point of observation. The slit light, however, does not appear sharp, and despite all attempts it cannot be made narrow. This proves that the coincidence of focus is lost. To re-establish coincidence of focus, the rays of the slit beam must be refocused. For refocusing of the slit light, the slit lamp may be equipped with a special focus attachment. Its purpose is shown here at the fundus. The microscope has been adjusted so that the target appears sharp. Now the slit light is adjusted by the focus attachment until it also appears sharp, and this eventually allows the slit to be made narrow. When the contact glass is rotated, the optical knife is also rotated. Let us analyze this. To obtain an optical section in the vertical meridian, the slit beam is oriented vertically in the central part of the contact glass. And in the mirrors positioned at 12 and at 6 o'clock. If the examiner aims at an optical section in an oblique meridian, the mirrors are rotated and the optical knife is rotated as well, as always, combining the rotation with tilting of the slit beam. For an optical section in the horizontal meridian, again the rotation of the mirror must be combined with the rotation and tilting of the optical knife. This means that numerous manipulations for adjusting the slit lamp are necessary when rotating the optical knife. Therefore, the voluntary rotation is cumbersome and is reserved for special cases. But for just scanning the eye in routine examinations, a less cumbersome procedure is preferred. For routine scanning, one may maintain the slit beam in a vertical position while rotating only the mirrors of the contact glass. But by doing so, the optical knife is involuntarily rotated. How does this occur? For example, if the mirror is at the 12 o'clock position, the optical knife on the fundus is on the vertical meridian through the eye. With the mirror at the 3 or 9 o'clock positions, the optical knife at the fundus is vertical also. But note, this means that it is at right angles to the meridian through the center of the fundus. If the mirror is in an oblique position, the mirrored vertical slit will appear obliquely to the meridian through the center of the fundus. Consequently, while the contact glass is rotated, the vertical slit is involuntarily rotated. Note, the obliquity of the mirrored slit is recognizable in the center of the contact glass as well. Therefore, by observing how the slit appears at the center of the contact glass from the outside, the examiner can deduce how the slit will appear at the fundus periphery. When seen through a contact glass mirror, the pupil appears as an oval and the horizontal diameter becomes smaller in some positions. As we remember, two bundles of observation rays leading to the microscope, as well as the bundle of the illuminating light, must pass through the pupil for a binocular view of the posterior segment. When observing through mirrors, only at the positions of 12 and 6 o'clock is the horizontal diameter of the deformed pupil large enough to permit the passage of all three bundles. However, when the mirrors are at the 3 and 9 o'clock positions, the horizontal diameter may be too narrow for the passage of all three bundles set side by side, and this may even occur with a wide pupil. In this case, one may use only one of the microscope bundles, but this means you have to sacrifice binocular observation. When insisting on binocular vision, illumination may be lost. This can be restored by placing the slit beam between the two microscope bundles, but then the light cannot be seen as an optical section. In case these sacrifices were to interfere with the required precision of the examination, the slit is rotated to the horizontal and tilted. Then the slit beam can pass beneath the bundles of the microscope and thus take advantage of the larger, that is, the vertical diameter of the oval pupil. This is shown here by a practical example, where the access to the lateral periphery is hampered when using a vertical illuminating beam. When the slit beam is rotated horizontally and simultaneously tilted, not only a good view on the ora serrata, but also of the peripheral retina is obtained. Obviously, with a narrow pupil, the difficulties of passing 3 bundles increases. The critical parameter is the distance between the 2 bundles of the microscope. Therefore, the access through narrow pupils can be improved if this distance is diminished by special optical devices such as the stereovariator. The observation angle is the angle between the observer, that is, the microscope, and the tissue surface under observation, or to be more precise, the angle between the rays of observation and the tangent to the observed tissue at the point of observation. The observation angle can be changed by asking the patient to shift the direction of his gaze, or by adjusting the position of the microscope, or by looking through the mirror of a contact glass, which may allow a nearly tangential view. By changing the observation angle, the geometric aspect of tissue, the background contrast, as well as the transparency of tissue can be changed. Let us look at the iris nodules in a case of von Recklinghausen's disease. The geometric aspect and the background will change when the iris is examined through a mirror contact glass and thus be observed nearly parallel to its surface. Now the globular shape of the nodules can be easily recognized, and when the nodules are observed against scleral backlight, their milky transparency becomes apparent. But changing the observation angle not only changes the geometric aspect, it also changes the transparency of the tissue, which, seen at one angle, may appear nearly opaque, but at another angle, transparent. How does this occur? Let us take a semi-transparent layer of tissue which produces faint light scattering. If this layer is viewed perpendicularly to its surface, the thickness met by the light rays is minimal for this given tissue. The number of scattering molecules is minimal, and therefore the view through this tissue is optimal. Consequently, at perpendicular observation angles, semi-transparent tissue appears nearly transparent and is almost invisible. If the same semi-transparent tissue is observed more obliquely, the thickness of the layer met by the light rays becomes thicker and there are more scattering molecules. Consequently, at oblique angles, the tissue appears less transparent and the tissue itself becomes better visible. This is shown here by the example of a detached retina. At the front of the bullous detachment, the retina is seen nearly perpendicularly to its surface, and therefore some dim red backlight from the fundus is visible. At the summit of the detachment, however, the retina is seen tangentially and therefore appears non-transparent and white. A similar phenomenon occurs in semi-pigmented tissue. If this is observed perpendicularly to its surface, the path of light through the tissue is short. There are few absorbing molecules, and the tissue will appear minimally pigmented. If the same tissue is observed more obliquely, the path of rays becomes longer, more light is absorbed, and the higher the obliquity, the darker the tissue will appear. This is shown here by the example of pigmented cysts in the anterior chamber. When seen through the front, the wall of the cyst is met nearly perpendicularly, and therefore one can see the bright slit light on its back side. When looked at through the summit, the wall of the cyst is met tangentially, and therefore it appears non-transparent and dark brown. Let us look at this again by the example of a fold. Where the tissue is observed perpendicularly, it appears milky transparent. Where met obliquely, it appears whitish opaque. Here at the top, it appears transparent again. here again opaque, and here transparent. Such folds can be produced artificially by scleral depression and may be used for improving the interpretation of findings, at least in the peripheral fundus. First, let us theoretically analyze what to expect from scleral depression. On top of the indented sclera is the semi-transparent retina. Underneath it is the more or less pigmented pigment epithelium, and below that is the choroid. If the indented protuberance is examined at its front, the tissue layers are seen perpendicular to their surface and therefore appear at their highest possible transparency. So one hardly sees the retina and can look through it at the pigment epithelium. Further, depending on the degree of pigmentation, one can even see through the pigment epithelium and look at the choroid below. Conversely, if the protuberance is examined at its summit, the tissue is observed almost parallel to its surface and appears the least transparent. The retina appears nearly white, opaque, and it hampers the view of the underlying pigment epithelium. This is shown in this example of scleral depression in a normal eye. At the summit of the protuberance, the retina appears white, and when the indenter is shifted backwards at the summit, a grayish zone appears as a mixture of white and black, caused by the obliquely seen whitish retina overcasting an obliquely seen blackish pigment epithelium. How can we take advantage of these phenomena for analyzing properties of the retina? For example, a partial thickness hole at the anterior face of the protuberance will hardly be visible because, for those rays meeting the lesion, the difference between full and partial thickness is small. However, if the indenter is shifted until the lesion is at the summit, the difference in thickness becomes large for traversing rays. This is shown here by a retinal hole just behind the ora serrata. When shifted from the anterior face of the protuberance towards the summit, the hole appears at high contrast because a previously invisible retina edema has now become white. In contrast, an alteration of the pigment epithelium is invisible at the summit of the protuberance. Therefore, the scleral indenter is shifted until the area in question is at the front of the protuberance, where the retina will appear almost transparent. Therefore, alterations of the pigment epithelium can be observed in detail at the front, but the same alterations become invisible on top of the protuberance because they are hidden there by the opaque retina. Note, now a previously invisible retinal hole can be recognized. To summarize the strategy for taking advantage of scleral indentation with changing transparency, if the goal of observation is the retina proper, place it at the top of the indented protuberance. If the goal of observation is behind the retina, place it in front of the protuberance. This is the end of the second tape of Part 1, Basics of Biomicroscopy. The next tape, Part 2, Practice of Biomicroscopy, will show the handling of the slit lamp for attaining optimal results.
The slit lamp is a combination of an observation system and an illumination system. The illumination system provides more than just general illumination of the eye. The illumination beam can be shaped to an optical instrument which can render invisible tissue visible. The illumination beam can even provide an optical dissection of the eye, as illustrated in Part 1. This tape shows the practical handling of a slit lamp by the example of the Model 900 BQ Hog Strite. For details, please refer to the manual of your personal slit lamp. A slit lamp has 4 components: the observation unit with the microscope, the illumination unit, that is, the actual slit lamp, the moving instrument base with the slide connecting the 2 units, and the headrest for the patient. This is the microscope. The eyepieces are equipped with a knurled ring. By rotating this ring, the eyepieces can be set to the refraction of the examiner. The diopters are shown on this scale. The eyepieces are designed for the observer's eye to be at a certain distance from the front lens, that is, the distance suitable for those wearing glasses. The examiner without glasses has to stay at this distance from the front lens and should not approach closer. To ensure the right distance is maintained, the eyepieces are provided with sliding eye guards. These can be extended to keep the observer without glasses at the right distance. The interpupillary distance can be adjusted. Here is the control knob for changing magnification between 6.3 times and 40 times. This is the illumination unit, which contains all the devices for shaping the light beam. The light is turned on at this rotary switch. By turning the switch clockwise, the brightness can be increased through hypervolting the light bulb. But note, this diagram shows that hypervolting not only increases the brightness of the light, but also shifts the maximum brightness towards the short wavelength. The hypervolted light contains more blue rays. This is the lever for interposing filters. A bird's eye view with the top of the slit lamp removed shows that shifting of this lever moves the following filters into the path of the rays. A heat-absorbing filter protects the patient's eye when examined with hypervolted light. Another filter reduces the brightness of the light beam. This filter is used for examination in red free light. And here is an empty position for filters to be added according to special requests. This control knob changes the diameter of the light and interposes 2 additional filters. A bird's eye view with the top of the slit lamp removed shows circular diaphragms for changing the beam size stepwise. The actual diameter of the slit is shown on this scale and can be used for measurements at the eye surface. Here is an oblong diaphragm for a continuous change. The beam, however, becomes asymmetrical at the extreme positions of the continuous diaphragm, and this affects the shape of the beam at the smallest diameter. Turning the lever to either ends interposes 2 additional filters, a cobalt blue filter for exciting fluorescence, and at the other end of the scale a test mark with a fixation star for the examination of macular fixation. This is the control knob for adjusting the width of the slit beam. A bird's eye view with the top of the slit lamp removed shows that the slit is narrowed and widened by a diaphragm with 2 moving jaws. This is the lever for changing the orientation of the slit. The angle can be read at this scale. This is the device for changing the inclination of the illumination unit. First, the latch for the angle of inclination is released, and this allows the tilting of the upper part of the unit in steps from 5 degrees up to 20 degrees. When is tilting necessary? Here, light slits can be seen on both cornea and iris. On changing the orientation, only one slit is to be seen. By tilting the unit slightly, both slits appear again. This is the mirror for directing the light from the light source towards the eye. The slit light is directed into the eye through the superior extension of the mirror. As shown at the microscope with the lenses illuminated for demonstration purposes, the long mirror may obstruct binocular vision at small illumination angles. To maintain binocular vision, the large mirror is removed and exchanged for a small mirror. The exchange of mirrors is facilitated by tilting the unit. The mirrors should be held at their sides because they are silver-plated at their surface and sensitive to scratching. The small mirror never obstructs binocular view. However, the small mirror has the disadvantage of catching only a small part of the light beam. For the transmission of the full beam, the illumination unit must be tilted forward by 10 degrees. Tilting the unit affects the quality of the slit light, which is perfect only with an upright unit. Then the beam is perfectly sharp and equally narrow. When tilting the unit, the width of the narrow slit light becomes unequal and the quality of the optical section is reduced. With a tilted illumination unit, a perfect optical section exists only when the slit is rotated horizontally. Therefore, tilting the unit requires a change of the slit orientation to horizontal. The microscope and the illumination unit are joined at the instrument base by a common axis, around which both rotate, so the illumination angle can be increased and reduced. Prior to using the slit lamp, the focus of both microscope and slit beam must be set right at the common axis to establish coincidence of focus. The focusing rod is inserted in the rotation axis of both microscope and slit light. It is rotated until the projecting surface faces the microscope at right angles. The focus of the slit light needs not to be adjusted because it is set by the construction of the slit lamp. But the focus of the microscope must be adjusted exactly to the observer's refraction. How is this done? The microscope is set at low magnification. The illumination angle is set at 0. Then each piece is focused until the observer sees the slit perfectly sharp on the projection surface of the focusing rod. The coincidence of focus is effective, however, only in air, and precision remains still satisfactory only in the anterior segment of the eye. But during the examination of the deep parts of the eye, coincidence of focus may be lost, so that the slit light appears blurred. In order to sharpen the light again, that is to re-establish coincidence of focus, the focal length of the slit light must be adjusted. This is done with the focus attachment, which changes the position and angle of the mirror from the clicked-in 0 position. There are situations in which the focus of the light should be set off-center, for example during examination in indirect light. How is the focus of the light beam set off-center? First, the centering screw is loosened. This allows a swiveling motion of the illumination unit, and so the slit can be set off-center. This is shown in the graphic. For recentering, the screw is fastened again, and then the illumination unit will automatically return to the position of coincidence of focus. The entire instrument base can be moved with the joystick. The general adjustments are made by shifting the joystick in the desired direction. For fine adjustments, just tilting the stick is sufficient. The level of the unit is adjusted by rotation of the joystick. To fix some of the angles and positions in a given setting, fixation screws exist. Here's the screw for fixing the horizontal movements of the joystick. Here's the screw for blocking the movements of the illumination unit, thus fixing the illumination angle. It can be read at this scale. The movements of the microscope can be blocked by this screw. At the headrest, the chin rest is equipped with paper covers, which can be discarded after the examination of the patient. For the same purpose, the forehead rest can be wiped with disinfectants if necessary. Before starting the examination, it is important to seat the patient comfortably with forehead and chin leaning against the appropriate supports. For maximum ease of examination, the chin rest is lifted until the center of the patient's cornea is level with the black marker ring. The black marker ring indicates the mid-position of the up and down movements of the slit lamp. Therefore, if the patient's eye is right at this level, it can be examined entirely by just rotating the joystick without any further adjustments of the patient's head position. This is the fixation device with the illuminated fixation target. Its starting position is reached when the prolongation of the vertical axis passes right in front of the patient's cornea. Then the patient's eye can be guided to the right and left by shifting about the vertical axis, and in all other directions by rotating the target around the horizontal axis. And this is the sliding lever for setting the illuminated target to the patient's refraction and thus preventing accommodation. To approach the patient's eye, the joystick is held maximally reclined in the direction of the examiner while shifting the slit lamp until the patient's cornea is in focus. By approaching the starting position in this way, all parts of the patient's eye can be reached with the slit lamp comfortably by just tilting the joystick. This part of the tape will show the retraction of the eyelids. Methods for inserting a contact glass. Removal of the contact glass. The eversion of the upper eyelid. Adjustments for the examination of babies. When retracting the eyelids, the main task of the examiner is to avoid any force vectors in direction of the orbital contents. This is no problem in the cooperative patient. In a difficult case, a cotton tip applicator may be used, which, to avoid force vectors towards the orbital contents, is not applied at the lid directly, but at the orbital margin, that is, just beneath the eyebrow. Pressure is not applied in direction of the orbit, but away from the orbital contents towards the bone of the orbital rim. But how is it then possible to retract the lid? The required lid movement is achieved by just rotating the cotton tip, which by this rotation pulls the lid upwards. Please keep in mind, while rotating, the tip is pressed always away from the orbital contents, that is, against the bone at the orbital rim. When inserting a contact glass, the main task of the examiner is to avoid any direct corneal touch with the rim of the contact glass cavity, which might damage the corneal epithelium. To avoid touching the corneal surface, the rim of the contact glass is first opposed to the sclera. In the method of the lower limbus, the patient is asked to look upwards. Then the upper lid will be retracted automatically. The lower lid is pulled down by the examiner with one of the fingers of the hand holding the contact glass. Look again. The contact glass, whose cavity previously was filled with a viscous lubricant, now is opposed to the lower sclera with its lower rim and then is tilted upwards until its concavity is in contact with the cornea, while the patient is asked to look straight ahead again. There is also a second method to insert a contact glass. It is usually a two-handed procedure. The patient is asked to look downwards so that the lower lid is automatically retracted. Now it is the upper lid which must be lifted by the examiner. This usually requires the use of the second hand. Look again. The second hand lifts the lid. The contact glass is now applied to the sclera at the upper limbus and tilted downwards until it is in contact with the cornea, while the patient looks again straight ahead. Two problems may arise while rotating the contact glass. One is traction on the lid margins and on the cilia, in case they were trapped under the contact glass inadvertently during insertion. This can be prevented by a careful check of the lid margins and cilia, which have to be removed prior to any rotation of the contact glass. The second problem is friction between the cone of the contact glass and the skin of the upper lid. By applying some of the lubricant at the surface of the cone, this friction may be reduced. Both obstacles which may cause discomfort to the patient can be avoided by the use of an enveloping funnel. This funnel is inserted first prior to the insertion of the contact glass, if necessary with the aid of a cotton tip. It is inserted in the same manner as a contact glass. The funnel's opening is carefully checked, and any trapped parts of the lid and cilia are retracted. The contact glass is inserted into the funnel. The lid skin is now protected from direct friction of the rotating contact glass. Removal of the contact glass requires the release of the negative pressure which may have developed in the cavity of the contact glass. In case of low suction, the contact glass gives way easily at the slightest pull. In case of strong suction, however, the globe will follow the contact glass on retraction. Sometimes such strong suction may be recognizable by conjunctiva being sucked into the cavity beneath the contact glass. To avoid damage to the cornea, the suction should be released by pushing the fingertip towards the globe just adjacent to the contact glass to let the air penetrate into the cavity. To turn the tarsus about the axis of rotation, which is an imaginary hinge line between the inner and outer canthus, the tarsus should be pulled downwards until its superior margin is slightly below the hinge line. The superior margin of the tarsus is recognizable by a depression appearing in the lid skin when pulling downwards. Note, an ample downward pull is the essential point in this technique. A slight touch of the fingertip immobilizes the upper lid skin above the upper margin of the tarsus. Then the tarsus can be rotated easily about the hinge. So the patient is asked to look downwards. The lid is slightly lifted so that the cilia can be grasped with 2 fingers. The lid is pulled downwards until the skin fold produced by the superior border of the tarsus is visible. The lid skin above the hinge line is immobilized. The tarsus is rotated and held back with the thumb pushing the cilia against the upper lid skin. Babies are usually examined in a horizontal position, lying laterally. In order to do this, the headrest of the slit lamp must be removed. First, the cables to the light sources of the lamp and the fixation target are disconnected. Then the screws of the headrest are removed. Now the headrest is taken away. A free connecting cable is inserted. A mobile tray is brought to the slit lamp, and the baby is gently laid down in a lateral position. Look how nicely the examination now can proceed. And isn't the baby sweet?